Welcome to the Innovation Accelerator podcast, brought to you by Innovaccer, the health cloud company. We're on a mission to connect and curate the world's healthcare information to make it accessible and useful. With Innovaccer, everyone works in the service of patients like never before as one. Visit us online at innovaccer.com.
Welcome back to the Innovation Accelerator podcast. This is Steve Ambrose. When seeing our providers, how often have we felt like number 32 at the deli counter? And how does a lack of doctors truly knowing their patients and recognizing them as consumers impact patient engagement, experience, care outcomes, and retention? Customer relationship management, or CRM, is used in healthcare, but it suffers from poor design, lack of 360-degree data integration, and the inability to work off a true unified patient record. And where other business verticals understand the wholeness of their consumer and customer, today's healthcare CRM offerings often have provider organizations walking east and never finding a sunset. Now, today's show takes a giant step forward in thinking, expectations, and evolution of the CRM as a catalyst for driving true one-to-one journeys between patients and providers. On today's show, we have Alexa Warner, who serves as the System Director of Consumer Marketing for Bon Secours Mercy Health, a health system that spans 7 states and includes 50 hospitals and more than 60,000 employees. Ryan Nagdeman is the Associate Vice President of Marketing at Rush University Medical Center in Chicago, a leading academic medical center and top-ranked medical college. Joining our guests will be today's guest host and consumer champion, Gary Druckenmiller, General Manager of CRM for Innovaccer. Welcome, guests. And Gary, I'll hand it off to you.
Thank you, Steve. And hello, old friends. Here we are in another day and another year, seems like another life of our CRM journey. It is very great to see both of you again. We've all spent a considerable amount of time together and couldn't have chosen two better confidants in our journey to talk about what I think is a pretty interesting topic that is fully coming to bear in CRM 2025 and kind of looking forward. So I'm very excited to get into that with both of you. But first, let's kind of hear a little bit about both of you, where you're at today. Why don't we start with Alexa? Alexa, why don't you give us a little bit of background on where you're at, what you've been doing, and then Ryan will do the same with you.
Sure. Thanks, Gary. And thanks for the invitation to join this conversation today. I'm excited to be a part of it. So yes, I am the System Director of Consumer Marketing for Bon Secours Mercy Health. We are a large integrated healthcare system that does span 7 states, and we're actually international. We're in Ireland as well, and growing what seems every day. So in my team, we have kind of 5 verticals. We have the consumer marketing component, where we do all of the marketing strategy, the campaign planning and execution for all of our markets. We have 10 markets that our system is divided up into. I have creative services that's in-house. We have an in-house advertising team that manages all of our digital trafficking. We also have a consumer insights team, so we do a lot of that work in-house as well. And then I also oversee B2B marketing. So all of the companies that we have adjacency to or ownership of, my team manages all of the marketing for those as well. So it's an exciting time to be in healthcare. It's also a very challenging time to be in healthcare. Every year I feel like we say, oh, it's changing, it's getting harder. And that's not news anymore. That's just normal. So right. I'm excited to jump into this conversation.
Yeah. So basically you got nothing going on. Every day it's just bonbons and just hanging out. Yeah.
Trying to, have a family on top of all of that.
Exactly. So it's just like, it's just a normal everyday life in health tech. Well, thank you. It sounds like you've got so much on your plate. Cannot wait to hear about it. Ryan, over to you, man. What have you been up to these days and what you working on?
Hi, Gary. Hi, Alexa. Thanks for having me. I look forward to today's conversation. as Steve has said at the top, Rush University System for Health. It's in Chicago, across the Chicagoland area, in a highly decorated, accomplished academic medical center with a system, community hospitals, many ambulatory locations, digital touch points, as well as our Rush University ranked also with U.S. News and World Report for Health Sciences Education. It is very similar to what Alexa had mentioned, working on demand generation, advancing our brand, bringing people to Rush, not just consumers and students anymore, but thanks to the Great Resignation, we have massive employee recruitment campaigns going on like never before. So it's a mix of everything in the marketing strategy vertical, alongside partnerships with digital, traditional, media relations, and creative and brand teams across the enterprise. So
Terrific.
Happy to be here, Gary.
Yep. And thank you again both for joining. I'm very excited about this. I could not have asked to have two better personalities in this industry who have kind of been through it over the past decade plus, and who can actually begin to look forward. And that's what we're going to move into now. The kind of looking forward notion of our theme today in terms of what does CRM look like in 2025? It could be 2023. It doesn't really matter. But it's important because I think for the first time, we can actually see how this is going to come together. And, for us, always kind of being at the bleeding edge of that's always been a hard thing to do. But now it's a little bit more clear. So I'm going to start off with a flash question, and Alexa will start with you. In 60 seconds or less, what does CRM look like in 2025?
What does CRM look like in 2025? I hope it looks like something that is much easier to use and understand. I think when we started working through this, 8, 9, 10 years ago, it seemed like an easy button. And I think what we've all learned is that it is far from that. But it has the capability to be. It's, as health systems, we've gotten in our own way. And so I think in 2025, I hope that we're unlocking the potential of what this type of technology platform can do for us. We just got to get our act together.
Great way to put it. Ryan, over to you. Same question.
Yeah, I agree. I'm hoping for less emphasis on the traditional words of CRM and customer relationship management. Emphasis on relationship, and that's really where we can be better. I think I've implemented some of these over time, and when I look at them, it's not as bi-directional as it could be, and as integrated as it could be. And so if there's opportunity to focus on relationship for not just the patient or consumer, but also the people interacting with them, and what tools and experiences could be better there, then it's more of a reputation engagement platform there. It's rep. I just changed it, Gary. Trademark it.
I love it. Ryan, I would say,
write that one down.
I would add to that and say, I think that when we started talking about CRM, like you said, Gary, a decade ago in healthcare, it seemed like this additional thing. And I think what we're seeing more and more now is as we bring new technologies online, they have to be brought online with an eye toward their relationship management. Meaning, as we're building our credentialing systems, as we're building our websites that are integrated, as we're building our EHRs and how they connect, and as we're acquiring and merging new hospitals, are they on the same instance? Do they talk to each other? As we're affiliating with, provider groups, where is their data coming from? And is it being gathered in a way that lends itself to the connectivity? I think that's one of the challenges we've seen a lot in a really large healthcare system is the potential's there, but the way that we're developing the inputs needs to come along.
Eloquently stated. On that note, Ryan, you brought up, before I jump to the next question, another kind of just quick flash, the naming. You threw out the name reputation. Is that do you think that's the predominant reference, or is there a particular term that you have kind of latched onto recently that kind of describes what Alexa was just defining?
No, I was zeroing in on relationship.
Okay.
And I think that would be the one that would pop out of all three of them that we would want to keep. I mean, certainly reputation is an area of focus with the B2B, that where we have a book of business as how we reach out for referrals, but also how we share with the influencers about the great work we're doing. And that's another component. We have a CRM for how we do outreach to B2B audiences, and it's disconnected from the other tools. It's like the Batman utility belt that's not really on the same belt.
Yes.
Some way I'm going to figure out a way to weave that back in. So, all right, great kickoff. That's why I asked that question first. So that now sets the tone for us to begin to slowly break down some of this. So let's take it a step further. Because there's a lot of conflated and somewhat interactive components that pull all this together. So what are some of the aspects of the health system itself with respect to design and function specifically? And Alexa alluded to some of them that have kept what we're doing from being a true consumer-oriented industry. And Alexa, maybe we'll start with you again, and you can kind of pivot off some of the stuff that you were mentioning a few seconds ago.
So what's preventing us from getting there?
Yeah.
I think it's not that complex. It's, the business that we're in is very interactional. It's very micro. We're, as a, marketing shared services function, thinking very macro. And so healthcare is still delivered one-on-one, and it is in real time. And so, when we try to apply principles from outside of industry for CRM and for relationship management and for overall experience, certainly there are learnings. We can always learn. But I do think it's a bit of a unique industry. And so I think that, and I think we're going to talk about this in a little bit, kind of this dichotomy between what is patient, what is consumer, kind of gets in the way sometimes. And there's times for each, and then there's times where they blend. And so, I certainly don't think our healthcare system has cracked that nut, but I think it's showing the value of interconnectedness with those providers that, they're not educated that way. Like, let's be honest, like they come out of medical school, our nurses come out of nursing school, like all of these people who are responsible for the interactions, they're not trained to think like this. And so we can't start at the end of the story. We have to start at the beginning. And, I think we're certainly coming along, but I do think that that's part of it, and showing the value of that connected conversation. And so in my role, I feel like a lot of what I do is I spend a lot of time talking to people within our organization. It's like being the champion of what's possible. So I could wax poetic about that for days.
Oh, no, I'm sure.
Stop.
Well, you mentioned it. It's the difference between bedside manners and consumer manners. Are they the same thing? I think that's what we're trying to kind of figure out, much to your point. Ryan, same question to you. For the industry itself, our health system, the infrastructure, like what in there else from your perspective is kind of preventing us from taking this leap?
I think it's time and investment. Over time, we have all in marketing, finance, access, care delivery. We've created supplemental tools over years that we've built on, patched, renewed, refreshed, that are hard to get away from, and that's why they're not blended in the consumer's best interest yet. And I think we are going at it. I think these conversations have been happening for years, but to knock down 5 or 6 silos that are multi-million-dollar, decade-long investments and find a way to bring them together, I think that's what's kept healthcare a little bit behind, and probably, appropriately so, because healthcare is kind of watching what's happening, and it's always had like a privacy, and you want the physician or the care person to sort of understand what we're prescribing. When things like AI and machine learning come into the possibility, you don't want to misdiagnose. You don't want to, give me medicine I don't need, or tell me my knee's fine when it's not, because it's a high touch, just like Alexa with the bedside manner. It's so high touch that until we're confident these tools can make it better across all silos, then that's where they blend together.
Thank you. The irony is that it took a global pandemic to even just a bit shake that system out of apathy, right?
Yes.
Like that's what it took. Weird. I liked your notion of, because I find myself that I say this often internally as well, obviously working at a data management company, taking that leap and getting into what you described as kind of like the AI world and the machine learning world and the data science world is not just a stepping stone set of events. It's a leap because like you said, if you're going to do that, it has to like work 100% of the time. Because if the automation is doing that much automation, it has to be pretty perfect. Yeah. Right. So that's, yeah.
And any of those teams, nobody set out to be siloed. It was really, it's like I have a doorbell. I have a security camera. Now they're integrated at my home. Like they found a way to make those work. Ring is the doorbell and the security camera. I mean, so it's as you look at how you can think about the consumer in mind and how to make those things better, then I think that's you're starting with what is the patient experience we desire, and then how does the CRM support it, and not vice versa.
Yep.
I also think we're operating in an environment that is not fully digital, right? So, and this was an aha moment when I joined Bon Secours Mercy Health, because prior I had been at two healthcare systems that had fully, if not predominantly, employed medical staff. So all of our points of ambulatory care, through to the acute to post-acute, they were all employed by us. We were all working off of the same medical record. And then coming into an organization like Bon Secours Mercy Health, where our legacy Mercy markets were on one instance of Epic, our legacy Bon Secours markets were on two separate ones. And then you've got all of the integrated physician practices we work with. So in our Richmond market, for example, about 70% of our provider workforce is affiliated with us. They're private practitioners, and there's over 100 groups that we work with. So when you think about the CRM and the relationship management, and you think about managing that patient's care from that first digital touch through to post-acute, that's literally impossible given the way that the data flows through. And so, we've got to find these connection points, and it is still through relationship building. And providers are not incentivized individually the same way that healthcare systems are. And so we're dealing with a lot of disparate systems to make this work. Yet, I do think we all have the end goal in mind, which is a connected, coordinated, positive patient experience. But it is a tough nut to crack.
It is, man, so well put that a lot of people don't like it when you say the word impossible, Alexa. Don't you know that?
Impossible.
Well, no, I'm jumping on it. I'm saying I'm agreeing with you, but because it is. But the key is, I think we all find, you just accept that. And once you accept that, then the culture can begin to line up to then what, as you so eloquently stated when you kicked off, the art of what is possible. That's like a mental breakthrough that we now have to get through. Cultures have to kind of rally around these very somewhat dramatic nuances that don't really get talked about a lot. So I love the way you put that. You mentioned it before, so I'll move on to our. So thank you for all of that. Those were fabulous answers. I'll move off to our next question. You had alluded to it. The question, the thing being consumer or patient centered, right? Like, which one is it? Which word do I use? So, Alexa, we'll continue with you. What is the difference? What's the difference between consumer care and patient care, Alexa?
On the one hand, I think that more and more they're synonyms, but they're not. So, I think language and understanding the origin of these terms is really important. We think about the term patient-centered care. That was really a movement inside of healthcare, 50, 60 years ago, to give voice to a patient in their care. 60 years ago, if I was an inpatient, my doctor wouldn't tell me what my diagnosis was. They'd call my husband or my father, depending on, where I was in life. And so there was this movement inside of healthcare that's, well recorded, to bring a patient and their lived experience to the center of their care, meaning that a patient's history, what they think, what they feel is really important, not only to the diagnostic process, but to their overall outcome, to feeling like an engaged part of their care. And so I think patient-centered care still really is about their clinical care. And I think we should let that be. I think when we think about consumer-centric care, so if you think about it as a funnel or, a longitudinal relationship, I think about the consumer piece as the unaffiliated, unconnected, unaware experience that a consumer possible patient could have with a healthcare organization as they're making their decision. Now, not every, community has options. We operate in some communities where we are the only option. And that is pervasive across the country. So, in an urban environment where you have options, that digital consumer experience on the front end to get them to choose you, I see as that consumer experience. When they move into the healthcare setting, then it becomes both and. So their consumer experience, in my view, becomes what they expect from the healthcare system in the periphery. So how am I getting my bill? What does this reminder look like? Is parking easy? Are they communicating with me in my chart? But the patient-centered piece of it, I think, still is at the heart of what clinical care is. And I think the mistake that, some of us have made is trying to blend those terms. It's like, let it be what it is. And we can have both, and there can be duality in that.
There was a LinkedIn post a few weeks ago. You guys might have saw it. It might have been Jared Johnson, now that I think about it. But this question came up. And then, of course, everybody worth their salt jumped in with some sort of narrative around it. And I jumped in and I quoted something I heard a long time ago. And Ryan, I'll pivot this over to you, because I think what Alexa was just describing was my answer. You're a patient some of the time, but you're a consumer all the time.
Yes.
I like that. Do you agree with that, Ryan?
It was actually going to be my same answer. I wrote that quote that you just referenced, Gary. Did
I steal it? Did I steal that from you?
Stole it. No, you copied and pasted it.
I probably did. I probably did.
When I see them both. I think there's an intersection coming at us, but I think of like wants and needs from a consumer standpoint. Amazon knows what I want. I mean, we've let it in, and I think then healthcare is something I need. I have an episode, and there's something that I have interest at as a patient. I need to seek a solution, and that's where patient-centered needs to be more relevant. And then the blend. I want to seek care, but I want it via telehealth. I mean, so then it takes my interests and needs into account. But I see an intersection ahead.
Yep. Some might describe it, and I think we actually might have titled an earlier podcast that I'd done this year, soft healthcare versus hard healthcare, which is another way of looking at it, right? We have got the deep clinical things, and that was kind of where Alexa kind of dove down into that, like getting that stuff is required to do the art of the possible. But then we have the soft touches, and telehealth being kind of one of them. Again, these things aren't easy to do, but they're easier to do than going in and having non-invasive orthopedic surgery and arthroscopic surgery on your shoulder and all the things that got to go along with that. Great answers. Gosh, I wish we had like 5 hours, because I feel like we could do this for 5 hours. So let me move to our next question. So why do you then think that we get, and it's the collective we, those kind of being in our seats and wearing the hats, the multiple hats now we're kind of having to wear, that we get pushback from clinicians on the use of these terms, and it's not even clinicians, because it's kind of a cultural thing too. Why do you think there's pushback on this consumer to patient thing? Is it historical? Is it cultural? What is it? Ryan, why don't you pick that up?
I don't feel that. And I think we do a pretty good job of allowing clinicians, providers who are trained to care and provide care to really focus on that. And maybe the areas where I see not pushback, but uncertainties when we try to talk about things like administration or financials or access. I mean, through education to be a nurse or physician, I'm trained just to heal. And that is where I should focus. Let the administrators, the marketers, the financials, the IT groups think about the consumerism, the tools we can make to improve that process. So I would say I'm not seeing some of that pushback on the terms, but I think there's more balance in how we can partner with them and not get hung up on the label. So I'd love to hear what Alexa's thoughts are on pushback of the term.
I've definitely seen it both. So when I was at an academic medical center, Ryan, I would completely agree with what you just said there. And I've come to realize, at least in my lived experience, I think that it comes down to how our providers, so our doctors, are paid. When they're protected by a comp plan and a salary, I think it gives them the headspace to just focus on that care and to focus on their research. That's a certain type of doctor. And I'm not making a comparison better or worse. It's just different. Being in an organization where we've got a little bit of both, I find that when I'm working with doctors that are on a solely RVU structure, they're kind of like their own little entrepreneur. And I don't mean that to sound dismissive, but they are. I mean, they care deeply about how much volume's coming in and are they having a good experience and what's the no-show rate and, what could their staff be doing to do that outbound calling? And so they do care more about what my team is doing and the value that we're adding and the growth that we're able to demonstrate on their behalf than in my previous experience at an academic medical center. And again, that's not a comment on their altruism. It's just a nature of we're human and you eat what you kill sometimes in certain organizations. So I think that's where I sometimes have felt that pushback. And I don't even know that I would use the word pushback. It's more of a discomfort of not wanting to see these patients that they truly care so deeply about as just a number. Yeah. And I think that they feel that when we call them a consumer, we're putting a number on their head and putting them in the deli line versus sweet Mrs. Jones, who I've been treating for her diabetes for 20 years. So I would use discomfort versus pushback.
Well put. It begins to also kind of smack to what is now being kind of called the disruptor class of modernistic healthcare models, speaking specifically to the retail health side. They almost never use the term patient, right? Because they're coming at it from the complete opposite end of the spectrum. Their doorways have been pharmacy, and now the early stages of screenings and vaccinations. And so they're coming at it from that really, really, really soft healthcare side. Maybe they'll pick up the term someday if they keep edging in, right? Particularly with commercialized high margin primary care services, which is where they are edging in. And so it'll be interesting to see how they pick that up, but great answers. Let's move over to data and analytics. One of our favorite topics to talk about, always the bane of our existence as digital marketers and CRM and consumer-minded folks. Data management and analytics have become critical, is even an understatement, to CRM performance, driving better experiences, driving better health experiences. What are some of the key and more specific performance metrics that you are both using to define success in your current CRM results? Alexa, why don't we start with you?
So, I'll tell you this, and this might not be a popular answer. I have started to think of our CRM as the thing in the background that we use to work within. I think, Ryan, you mentioned this earlier, it's not at the forefront of top of mind thinking because it's baked into how we work. So when I think about KPIs in my work and my team's work, we're looking at, overall our brand, the awareness, the likelihood to recommend, loyalty from the true brand perspective. We're looking at, understanding in real time operational readiness with our teams to understand where they really do have an opportunity to grow and what that capacity looks like. And then setting really aggressive growth goals that we develop strategic campaigns to implement, where we leverage the CRM to be very nimble and the ability to track those campaigns and how we're influencing behavior in real time, which is incredibly helpful. We are making changes all the time, which is a wonderful thing. We didn't have the ability to do that pre-CRM. We would just put it out there and anecdotally we'd know in a few months if it worked or not. So it's been incredibly beneficial in developing relationships with our providers, which ultimately is helping us ensure that, the right message is hitting the right patient at the right time. So it's almost like a return to more basic KPIs to understand success, like really getting back to basics of what does growth look like? What, are the high levels of a positive experience? And are we nurturing those leads that are in our funnel and keeping them loyal? Do they keep coming back for more?
Good. And with a looming, what's likely to be 100% guaranteed year-long inflation, recession. We're in an inflation recession coming up. No more is growth important. HMA just, they've been doing a whole series of their kind of advisory sessions over the past couple of weeks. And the big one came out yesterday with COOs, and the top one is growth, and just trying to recoup what is already being predicted as lost quarters well into 2023, excuse me. So Ryan, same over to you. Which metrics do you agree with Alexa? Are you kind of toting the same line, or do you guys have some varying degrees of metrics that are preparing for something else that you guys are working on?
Yeah, no, I see the evolution. For how many years we'd go in with, back when the digital reach was newer and you could wow with the million, like we had 1 million impressions. And,
I know. Yeah.
And it's like, I'm done. I'm good. Like everyone's impressed with
way back in 2015.
I know.
So long ago.
Yeah.
Now we're like, that doesn't matter.
but that you track so much more with digital tools, but that funnel has never gone away. And I'm glad, Alexa, you mentioned the awareness and some of our CRM marketing campaigns that I think the most important metrics now are almost flipped. When you get to the bottom of the pyramid and it was like, well, how many did we get? I think we're looking at metrics around conversion to appointment, new to the system. What does that mean for growth? Those are the more important metrics now. I think back to the 20 some years ago, 10 years ago, it was the top of the funnel. How many digital impressions did we have? We used to get excited about a digital impression, millions, and then some people clicked on it, some bounce rates, but really it's now the business metrics, which are the ones that we're sort of hovering around now, and then looking at the success in how successful was that campaign, thinking about propensity for disease when we looked at reaching out to people who may be at an age range or have conditions where we thought they may need bariatric or heart or orthopedic care, and they converted. And that reinforces the importance of knowing the customer that we're marketing to.
Yep. I've used the term internally a little bit. Great answers as usual. Or the phrase that I really feel, although we've really been trying hard, but more so than ever, I feel like leaders like yourself are in a position now, and others and your peers, to kind of save the day. That the tools that are mechanized, the data that is mechanized, the content, the messaging, like kind of how Alexa put it, it is kind of in the background. It's like the chip inside, right? The Intel chip inside that's kind of doing all the work, but you don't see it. But man, it's tethered to everything that really runs the consumer or patient layer of connectivity, from the entire layer of the administration, which is typically where the goodness stops. So it's minds like yourself that are now put in a position to articulate these things in a way across all of it. Because I know like Alexa was even hiring for like clinical communications jobs. Like that's brilliant. Like that's what's needed. And that keeps the whole thing rolling. But then you are the imprimaturs of, as you both said, growth, loyalty, and not just acquisition, but retaining the best families and patients to the system the brand name really being recognized for something beyond just that clinical moment, but the everything moment, the full longitudinal moment. I truly do believe that. I feel that the time has come for that to happen. And there's no better groups to do it than kind of the consumer-minded people, because that's just generally how they think. Great answers. So let's move off of that for a second, and then kind of come back to some more of this kind of subjective natures of CRM as opposed to the more acute objective things. And we'll bounce back and forth a little bit. Let's talk about personalization, something that's very near and dear to my heart. And we'll get more into this as we kind of move on. Tell us a bit how you see, again, the reference of CRM. And I agree with you. I think that term is eventually going to go away to something far more dramatic and connected, right? Because it also has a history to it that I'm sure none of us really like anymore. How do you see CRM improving personalization and accessibility? It's meant to be innovative, but how does it really nudge the personalization and accessibility story forward? Alexa, why don't you pick that one up?
I've been thinking a lot about this as we've been planning our annual marketing plan for 2023. And, as we're looking at the channel mix and how we're going to target folks, I don't think we can have a conversation about personalization unless we're also calling out the truth of privacy, and how that's changing, and how, more and more people are opting out of, sharing their cookies or being tracked online, or that people even know what that means. It was like our secret weapon 5 years ago. And we were a force for good in healthcare with that secret weapon, right? Like, we were going to use your information to help you. Help yourself. And now people are aware of that. There's, you can get a private VPN. You can tell your Apple iPhone not to track your online behavior. And so I think that where, even a year ago when I thought about personalization, it was very nuanced, and it was very about Gary and his behavior online and how that looked. Now, I think that's still going to be possible if Gary wants that. If Gary doesn't want that, I think personalization has a different definition. And I think that we go back to the patient-centered care, and I think we look to our electronic medical records and those systems to provide that level of personalization in the way that we're communicating with our patients in real time, and making sure that they're only hearing from us when they want to hear from us once we attract them. So that's another one where we could spend a whole hour talking about that. But that is top of mind right now.
Yeah, well, maybe we could dive into this one a little bit. Bear with me. This reminds me of a dad joke. It's a literal dad joke. So I went to a website to learn more about my diabetes, and a notice came up that said, "Do you accept cookies?" Is that a trick question?
That's a
case
good one.
in point. There's personalization, and then there's personalization. So, Ryan, what are your thoughts on accessibility, personalization, how CRM kind of supports that, and what its objective should be?
Sure. I think it's a complete view of the person or the entity, sort of surrounded, by the business objectives. At a place like Rush, a consumer, someone in the CRM could have 5 identities across the spectrum of an academic medical center. I could be a student, a patient, an employee, an alum of the nursing college, as well as a donor through philanthropy. And because of the silos, we've kind of brought them up over time. I could get an email asking me for a gift today that's, on the same day I'm having a hospital admission. It's like, come on. And so I think as you sort of build the collective foundation that can look at me from all views, that has all the proactive, the reactive, the AI that would say, don't send him a solicitation for money. He's having a colonoscopy today. I think that those will, make it a little bit better, have some governance and guidelines around how you deal with me, because until then we're bumping into each other.
Yep. And where is all of that rooted in? It's data again, right? Like most of these answers, we have these high wishes because we can see it, right? We can probably literally map out all these things right now, but we're relegated to, in some cases, not even just poor data, but kind of rotten data, which affects all of those things.
Yeah, and to your point, though, it's if you could trust and rely on that, it can automate things that require one of us to flip a switch today. And I'm going to get that refill 99% of the time, but you have to wait. You have to call, for someone with the medical. I mean, I'm not a doctor. Obviously, we all play one on TV, but in the scenario where they would refill something, you're waiting for human interaction. And let's say 100% of the time that would be refilled. Data will tell you that, and it's okay. Then could that be automated? That's one scenario in a million, but that's where the tools can help and check a box.
Alexa, how does this? Let's stay on this theme for one more round. How does personalization, in the degree that we're talking about it, which is fairly highfalutin in nature, we can see in this term one-to-one, you mentioned it before, I'm going to bring it up again. That's really what we're talking about. And that's not easy to do. So how does that influence results in other areas of system and provider operations and care? So let's not just take it for ourselves. Who else benefits from this? And how does it influence their results across the full continuum of care outside of a marketing lens or just a consumer lens?
Yeah, absolutely. I mean, I think it goes back to when we think about patient engagement. Patient engagement does not mean that they're reading a blog post or they stayed on a landing page. I think that's part of it. But engagement means that they are showing up to their appointments. They're taking those medications. They're taking an active role in their health. So, one of the things we've done at Bon Secours Mercy Health, and we're in the process of doing, is we've developed our own app. That it's available in the App Store right now for Mercy Health, and it's coming out for Bon Secours later next year. But it is the digital intersection of all of these tools. So it's a window into your MyChart. Epic is our EHR. There's different opt-ins that you can have, and so in your pocket is if you want it, if you download the app and you're a patient of ours. Or if not, you can also download it if you're not a patient of ours. You just wouldn't have the MyChart activation. But putting the personalization back on the patient. We're not going to push this on you, but here it all is in this one place. You can make your appointments here. You can do your e-visits through the app if you'd like. You can message your provider, but you can also search our website for content, or you can hit up the blog for information, or you can engage with a social post or upload a photo and, say thank you to Bon Secours or to Mercy Health. And so I think some of it is through, when we talk about outside of industry, there wasn't a solution that existed for that. And so our organization stood up a team to create that. Now it's not perfect. It's still very much, a work in progress, but we kind of see that as the opportunity to connect all the things in one place, including our enterprise contact center, which is still that human voice that you can get on the phone at any given time. So I think a lot of it is going to be continued innovation with examples like that.
And a very important human voice. We can't forget that as we digitize everything. Yes. Ryan, you feel the same in the areas that Alexa mentioned? Are they resonate with you? Kind of beyond your pure purview, do you see those impacts being heralded elsewhere in other areas?
I do, and I would add to it in absence of an integrated CRM across all these verticals. I think when we end up there, it'll be because of some of the work we're doing now to think in a more patient-centered way, and we are manually finding business opportunities in lieu of having the ultimate solution. We will never have the ultimate solution, but to sort of look at things, and we're pulling manual levers, sort of taking data from one vertical and then putting it into an email marketing tool to build upon an experience or help someone pull another lever. It's manual, but I think we're getting at it. We're building the use cases for the CRM of the future because we've been thrown together. And I think back to your point about the pandemic eliminated in a hospital setting, eliminated every other priority. We had 5,000 things going on, and then it was only about one, thinking about taking care of the patient. And so I think that closeness, those teams we worked with that we may have known existed, we were elbow to elbow in command centers during COVID, and now we haven't forgot about them. It's like, wait a minute, I learned something from you during that. How can we continue to work together? And that's present at Rush. I know it's present at many hospitals and systems across the nation.
It's a great point. Being thrust into situations like that, again, it's obviously, I was going to say unfortunate, paradoxical to what we're really beginning to get ourselves into, and it's going to turn out to be an oddly good thing over time. I think we all feel that because we can, again, now begin to see the inherent interests, because department cohesion, we know, has always been tough. But now we've been, like you said, I think you used the term thrust together. Like that's a really good thing. And once we can beginning to start seeing similar alignment when it comes to that, this question was heavily intended to kind of drive that notion, and that we can all rise on this ship with these things. And I think that's becoming an interesting theme of our discussion today. Let's dive back into the data piece again. Alexa, I think we did an assessment together. Didn't we do a CRM assessment in our past lives? I think we did.
Yeah, I think
so.
We did too.
We're still doing that here at Innovaccer, and the classic CRM maturity assessment is an important exercise, because one of the hardest things for all of us to do on any side of the fence is determine where are we at now and what are our priorities and where do we want to be. Like, just asking that very simple question is a hard one. I mean, it really takes some microscopic discussion and breakdown of all the variables of what these things are meant to do, and then determine, where do I start? That's literally the question on the table. So we did one recently in a kind of a broad way around best practices, and more than 2/3 of the respondents showed what we'll call significant shortcomings in the types of data they utilize, the inability to bring all of it together. Again, classic story. So the question to you is, what types of data are both Rush and Bon Secours, organizing, and where do you take it from? How do you integrate it? And then then the follow-up to that is, how do you then use it to strategically communicate in a consumer-centered way? So I'll back into it again. What data do you grab, organize, and then try to pull together? We've talked about that in a few different instances so far. And then how do you use it in the consumer-minded way that we're talking through on our discussion today? And Ryan, why don't I start with you on this one, if you don't mind?
Yeah, we know so much about people's health condition, but I think what's missing in that relationship tool is the, how do you want it? And we haven't recorded that yet. We may have it in notes in Epic, like Ryan likes iced tea, but we haven't gotten that is how to deliver it, and do all the groups across the hospital know that? And so I think it's that conversation. It gets back to the top, the relationship component of where we're going. We provide care like no one else. We're at the top of the U.S. News, the Vizient, CMS. It's the experience and the relationship management. And our CEO is thinking about his like, let's make it like it is on the app. I get flight notifications. I'm walking down the hall. My physician's going to be 5 minutes late. It shoots me a Starbucks coupon. I mean, that is improving the patient experience. And that's a vision that we have at Rush, to marry the experience to the level of the quality of care that we have. And so the patient needs to be part of that and have be part of that conversation. And I think until we're truly there, we're just providing great care.
One of my favorite pastimes is taking claims data, de-identified claims data, third-party household data, media data, and then provider data, and pulling it all together in an Excel sheet and putting it in a pivot table. That's one of my favorite things to do. I absolutely love it. It's so much fun, and it's so efficient, and it satisfies all the interests that you just mentioned, Ryan. It's great stuff.
Gary, you've got a lot of time on your hands.
I do. I just sit there. I'm just like, wow, this is fascinating. Billions of rows of information. This is going to be easy. Alexa, well, the question to you, obviously it's a joke, but man, how many conversations that comes up? I'm like, I got this doc over here and I'm like, what? Are you crazy? Yeah. So the same question to you, what information are you tapping into? How are you currently kind of pulling it all together in order to do some of these consumer-centered, and it's a data-centric question, right? So over to you, Alexa.
Yeah, so all the types of data you mentioned, Gary and Ryan, we're doing as well. So, we've got obviously the data in our EHR systems, we've got claims data, we've got state data, we've got, third-party data that we pull in that is, blinded to, or not blinded, but is not necessarily our patients. We capture preference data. So we are an opt-in organization. So we don't assume upfront that every patient's going to want a marketing message until they opt out. They have to opt in. And so that's been, I think the nature of our organization being a Catholic healthcare ministry, that is the direction that we've chosen to go. But it is limiting. I mean, we do not mine our own patient data to understand propensity about Mr. Jones. That data is coming from my team, from insights, or from third-party propensity models, really deep dives with our strategy team on demographics, by neighborhood. And so that's been really interesting and fun, and layering all that together to kind of paint the full picture of who are these people, what do they need from us, and do they want to hear from us, kind of first and foremost, to create those experiences is the way that we do that. But it's not perfect. I mean, there's still so many opportunities. We started a product called My Health Club that is opt-in. And so it's a cut above information around your specific disease type, and it's a content newsletter, and it's been slow going. I mean, we've got, several thousand in that pipeline, but when you're serving millions of patients a year, that's a relatively small N. So we're trying to create those pockets of value where it makes sense with the data that we have. But, going back to what I said at the top of the conversation, when you're working in an organization where the data is bifurcated between outpatient and inpatient, it is very difficult to have a full view of that patient's continuum of care. And that's something that we talk about a lot. It's something that we're working to solve from. And it's really become a marriage of the power of the CRM. And like you said, Ryan, very manual processes to get at what the right thing to do is.
Fantastic. Long story short, for all of us, we are, I think, on a pretty broad, time-consuming, in a good way, and excessive march towards capturing even more than what we can get our hands on today. And maybe I'll just throw this out as a side question. This wasn't something that I was planning on asking, but in order to kind of connect the journey, which is kind of a common frame of reference that I think we're all using today, the end-to-end, first point of contact through life. My guess is that the visibility we have to do that in a way that is tantamount to how you are all describing this 2025 vision. My guess is that we're only really accessing 30 to maybe 40% of the needed information to do it. Is that about right? Is it higher, lower? Ryan, what do you think?
I don't know.
Yeah, it's tough. It's tough, I guess, to put a number on it. Alexa, do you have any thoughts on that, or is that number on point, or is it off point?
I think it's probably on point. I also think it's probably generational as to the amount of data that we have. I think about my own family. My grandparents are loyalists to a particular brand. My parents are, for the most part, except when it's inconvenient and they'll shop around, but they'll go to a larger provider. My husband and I were loyal for a component of our care, but I have 2 young kids and another one on the way. if I can't get in to see a pediatrician that day, like we're going to KidMed. Like I'm not waiting. It doesn't matter how loyal we are. So I think that, I think it is fragmented. I mean, ideal state would be, and again, truly from a data perspective, there are so many other implications for this, but if that data was freely available so that, my son's primary care physician at provider X could see that the notes from that KidMed visit easily, that's coordination. But that's also not the society that we live in. So,
right.
So yeah,
I love your comment. Yeah, I love your comment of being generational, because we haven't actually talked about that, but it's true, man. I'm seeing. I'm no spring chicken anymore, but I'm seeing stuff that's even like passing me by. I'm like, what is that? Like, am I supposed to relate to that? Is that something that's going to help me and kind of benefit me? So the general, I appreciate that. And that's something that needs to be talked about more, is the confluence of data and information across a short period of time, but multiple generations in that time. Mm-hmm. And that's something that doesn't get talked about a lot. Well, we have talked about this a few times, the notion of journeys. So let's jump over to that real quick. And as we're kind of in the final stretch here, one of the most commonly, I think we would admit, missed opportunities for any provider organization, and even retail organizations, even the ones that do actually have somewhat of a consumer centricity that is ironclad in nature. Even they haven't quite figured this out yet. But most on our end, what we found is that most provider organizations are a little bit behind the eight ball on this, is the lack of mapping journeys. And so consumer and patient. And again, we'll separate them for the sake of conversation, noting that some go very in depth on the patient side, some are a little lighter on the consumer side. But it's just not happening enough. I'm talking like the literal mapping, step by step by step, as somebody moves through the administration and through the buildings and through physician in offices and all of that. Like, not easy to do. So I'd like for you to share your thoughts on how you could articulate the mapping of what we actually call here, what I call a health one-to-one journey, and some of the tips and strategies that have been helpful in your performance and results of doing these types of things. As light as it might have been, or as heavy as it might have been, I'm curious of your thoughts on it, and some of the strategic angles of entry that you've taken to get into that work. Ryan, why don't we start with you? Yeah,
use cases, personas, some of these journey maps that we've maybe created for our silo in a website journey map, and how they'll search and use and then convert. I think the opportunity that I'm seeing and through collaboration across the health system is when you can start to layer them over each other and not think of them in isolation. And so really it's that, and there's more commonality there than we knew. So I think we're just getting at that, and more of that is necessary to say, wow, you're trying to do that too, and I think that's how I'm curious about the health one-to-one journeys. I think that's kind of what you're thinking about holistically across a hospital or a health system. And so the more you can do that, the more you're pulling resources and project objectives together. It's not a marketing project. It's not a knowledge management project. It's a consumer project. Will be how we achieve that.
Alexa, same question over to you.
I think this is so difficult and requires a lot of, honestly, manpower to get it right. I'm sitting here thinking about bariatrics, for example. So in my role, we have 10 markets. We have like 7 bariatrics programs, right? And so theoretically, as a ministry, we have 1 bariatric service line, right, on paper. But then it's really 7 service lines. And then if there happens to be 2 programs in one market, let's say there's 2 in every market for the sake of argument. Now we've got 14 service lines that we're really thinking about here. And so, we've got a system website that consolidates things, and we've got 1 digital journey for bariatrics. That does not work for those 14 groups. So, where my team has really done a lot of heavy lift with our strategy team and with our medical group colleagues, partnering with our service line leads in market, is really getting, in a virtual room, and walking through okay, let's start. There's 3 front doors. Great. Let's go through each front door and talk about what that looks like. And then work with them to say, okay, we're not here to change your processes. We're not here to this is your show. You tell us what's working. And then we'll kind of reflect back to you where we can add value based on your goals. And, that's been, since I joined the ministry almost 3 years, a process specifically with bariatrics of getting to a place where they are now using one unified web form to request an appointment or to have that seminar. And so, we talk about efficiencies, we talk about operating at scale, and I think that's certainly the goal to a degree. But when healthcare still is delivered one-on-one, and that surgeon is the master of their practice and they want it a certain way, you've got to look at every journey with distinction. And so I would just say it's a very heavy lift, but it is a critical component of running a well-executed campaign and to deliver on whatever promises you're making within that campaign. Without that, it just falls flat and it does not feel like a genuine message.
Yep. One of the other things that came up in some of these HMA studies was, and it's not anything inherently new, but they're trying to get a little better at articulating it, is automation, efficiency through automation. And that is obviously a direct outcome of workforce reduction, right? And like Ryan, you mentioned, like employee recruitment. I was on another call the other day where an employee recruiter was actually on the phone with us because they were that interested in what a CRM system could do to help hire not physicians, but basically anybody. Right? All right, so that's interesting. But what they're trying to solve is much of which we've really been kind of, again, cascading through our conversation, is this degree of automation to pick up some of the handle on all of these manual moments. But now they're doubling it down on this, it seems, in a lot of different ways, because sometimes the manual moment isn't even there because there is no manual. There's not enough people to do it. So now we're basically we're creating new holes that need to be immediately filled because we can't find anybody to fill the manual holes. So now we're forced to automate it. So my question with this is something that Ryan alluded to before. And Ryan, maybe I'll give you first shot on this. How do things like and I don't like using the term, but AI, machine learning, basically these smart algorithmic engines, how do you see things like that helping with this whole health one-to-one healthcare journey? Like what should their objectives be to help facilitate some of this automation?
I go back to the objective sharing. If we can look at things in not purchasing the AI tools and then figuring out how to work with it, because that is the shiny object. We've got a shelf full of things we bought and don't know what to do with everywhere, including my home. And so I think it's getting at a consumer first mindset. Our website redesigned just 2 years ago, very similar to what Alexa was describing with the bariatric, the 14 different models. Consumers don't know that. They don't know that you have 2 of them are private practices and 12 of them aren't even real. But I mean, it's getting our website redesigned, flipped to a consumer mindset first, where you could find out that we do orthopedics. And there are 3 flavors of it behind the scenes. There's a private practice, there's an employee practice, but we presented it as Rush provides the best orthopedic care for you. Where do you live? And I don't live near all of those practices. And so operationally, we ran into some headaches with the website consumer first mindset. And so I think to define projects like that, how you want it to go, then look at how does AI make it better? How does machine learning make it better? Voice-enabled tools. Call center would be the first one. Now that our access center has done great work over the last several years to bring all the access centers into a central governance and tool set. And if they call, 5 years ago, if it was, I'm calling for an appointment at this location only, my script has 2 options. I can get you in or I can't. Sorry. Now it's, I can't get you in there, but you can see someone in 2 days if you drive 10 more minutes. And AI or better tools propose those on the user operator's interface, or if you're doing it online, it can automate all of that. You don't even need to do the phone call anymore because it says, hey, do you want it? You can pick one in the pyramid. Do you want it to cost, get it sooner, or have higher quality? And this is, these are your options. And so I think that's what we would be getting at: convenience, choices for consumers, where we can cut out the middle operator who has to handhold and be on a call for 45 minutes. Let them spend 45 minutes on a call with someone who really needs help with care navigation.
Man, you touched on so many important topics there, and I'm going to move to our last question in a second, but one word I just wanted to comment on is a term you used was options. And that's been the whole notion of convenience and options is huge and much easier to execute in this, again, the soft healthcare framework as opposed to the hard healthcare framework. Those options they're still there, but they're just harder to execute with these types of tools because there's a lot more data that lives there. So in order to apply AI to that, and that's usually where the data is not that great, right? So I like how you kind of started. It's like, well, if you're going to do AI requires almost near perfect data to work. So how are you even going to institute this? I haven't even cleaned up the mess in aisle 5, and you're already putting a brand new Ferrari in front of me. It's like, come on, right? I totally agree with you. But it is easier to do on the opposite ends, right? In the non-clinical framework, it is an easier thing in theory to do in the marketing and access side, which is exactly where you dove in at, and the lifetime kind of retention communication side once they've exited the system and are out being healthy. It's a little bit easier to do there. Still not entirely easy, but at least easier. Great comments. That's what I was hoping to hear. We're winding down. I have but one more question to ask both of you. So think like Thanos. No, I'm just kidding. Well, maybe not. If you could snap your finger and make just one single change or improvement in any aspect of healthcare and your role, however you want to define it, what would it be and why? Alexa, you go first.
And the answer I'm going to give, I should give some context for. So I'm just close to this personally. My husband is a physician and is in medical education. And so, healthcare is something we talk about all the time. And we bring our problems to each other to try to sort through, how does your side of the coin think about this? And how does your side of the coin think about this? And it baffles me to no end how many times I thoroughly surprise him by what I'm saying. And it goes back to a comment I made at the top of this hour that, when I was getting my master's degree, for example, we had to shadow in the hospital. I took a medical terminology course for 3 semesters. Like, it was an expectation of, okay, you want to be a healthcare administrator, you got to understand this industry. And being very aware of how this industry is changing and how providers are compensated and payers and all the things. That level of learning, on the flip side, does not exist in medical education to a broad degree. And so what is happening is we've got this convergence of professionals that don't necessarily understand the value that each other is bringing to the table and how we can work together and help each other. There's still an us versus them, I think, paradigm in some ways between administration and, our provider workforce. And so, it's like the doctor who's an amazing surgeon and is then, asked to take on a business role because they were a really good doctor. I would not be asked to be a surgeon because I was an excellent marketer. So, it's 2 fundamentally different skill sets. And so I think coming together, understanding, starting at the point of learning and education, of having environments and culture of learning and asking questions and really striving for that. I think that's going to be the thing that, that's my big philosophical answer. that I think we've got to start at the beginning.
It's a great one for somebody who literally and physically has all of this too close to home, right? It's
well, I was reading a blog post recently. I'm currently expecting my third boy, and it was talking about raising the next generation and how, if you're teaching tolerance and love and acceptance in your home, and if we all did, imagine what this next generation would be like. Now, maybe that's a pipe dream, but it made me think about this question, Gary, of we have to start at the basics. And I think the knowledge that we learn in the classroom as, professionals that come together is critically important.
Yeah. And again, for you, I mean, hitting too close to home is kind of a little bit cliche, but you're charged, especially with soon to be three young children, to bring them into an environment that is better than what you're having to deal with, right? Because now you're sitting there, I want these boys, God bless you, by the way, to not have to deal with the misgivings that has gotten us here. So I am going to spend all of that time, and I'm going to have that impact and make sure that doesn't happen. That there's got to be more of that, right? And those are the individuals that I think kind of have a tendency and a desire to kind of try to break out of the bureaucracy as much as they can. I love your answer. That's why I kind of felt I'd start with you first, obviously, knowing that you got two healthcare people living under the same roof. Ryan, you get final word here. So snap your fingers. What's the one change in healthcare that would make you sleep better, get you up earlier in the morning, really jazzed about everything that you're doing? What would it be?
No, right on, Gary. I picked up on your Marvel Thanos reference, so I would snap it and get rid of half of my problems, right?
Perfect. Perfect.
Avengers something, but I think I was channeling with Alexa there. It's how we all get along on the provider and administrative standpoint to have a mindset. I'm me, I'm not a marketer. I'm a healthcare provider. How can I make the patient experience better? Everyone who has, in your one-to-one touch point, who has a engagement with a patient, from the Google search to the valet, the valet who greets that patient at the front door and maybe has one of these mics here where they say, hey, Ryan's coming up for his appointment. I mean, could technology be that much better, along the way? Okay, I know he's coming. I'm greeted. They know what's happening when I hit the floor, and I don't have to wait as long. Or someone said you could improve all that continuum. Everyone's part of the healthcare delivery system, and there's a melting of what Alexa was saying about the administration versus the provider. I'm not the provider. We have to get the patient to the provider. That's where the sweet spot is, but we're part of that delivery. And so I think when you do that, you wipe all that away, then we can get at, things like in building upon it. There's excellent care delivery. What's beyond? I think that comes when we all have the healthcare hat on, and snap, snap, snap. That's why we need 2025, my friends.
What are the best way to finish? I didn't come around on one of the other things I said I was going to do, but I don't want to now because we're just going to finish with snap, snap, snap. We're going to end there. This has been a blast. It's been good to see both your faces again. I saw Ryan at SHSMD for a hot second. But Alexa, look forward to seeing you face to face again. Thank you both. This has been wonderful. Your answers were amazing and courageous as usual. Steve, I think we have consumed everything we can out of this topic. I'm going to throw it back to you.
Well, great. Our thanks to Alexa Warner, Ryan Nagdeman, and Gary Druckenmiller for taking their time to enjoy an insightful conversation on the future evolution and needs of CRM in healthcare. And for our listeners, don't forget to check the show notes for links to resources and contact information related to today's show. And stay tuned to the Innovation Accelerator podcast for more shows covering the healthcare IT topics that you care about. For more information on this and other healthcare IT topics, please visit Innovaccer.com. I'm Steve Ambrose, wishing you a great rest of your day.
You've been listening to the Innovation Accelerator podcast, brought to you by Innovaccer, the health cloud company. Don't forget to check the show notes for links to related resources and other information. And stay tuned to the Innovation Accelerator podcast for more programs about the healthcare IT topics you care about. Accelerate your transformation and build the future of health on the Innovaccer Health Cloud. For more information, please visit Innovaccer.com.